I can speak for myself and say I breathed a sigh of relief after the election, but I think I'm now holding my breath in anticipation of what's coming. So to quote that famous scholar, Yogi Berra, predictions are difficult, especially about the future, but I'd be curious from Grant and John and Jen, best case and worst case scenario in terms of the final determination of the budget discussions, what we might anticipate, what may be most vulnerable, and what kinds of things are you comfortable, no matter what happens over the next few months in terms of what might influence HIV and viral hepatitis policy going forward?
Yeah, I think that the president has made his priorities clear, and I'll limit my comments to that.
Okay. Okay.
I'll go with that. No.
Okay.
Well, I don't have to say that. I think there's a lot that we don't know. I think the general feeling in Washington, though, is that we're in a better place to find a solution that is not as detrimental as it could be or as we thought it would be. I think there will be some kind of this compromise, but I don't think it's going to be without pain to programs. I think that's the unfortunate reality, is that we're going to start seeing the impact of some cuts and other things, not at the, again, the sequestration probably won't happen. And there's a real desire to avoid that, but it's I think we're in a very tight situation. And obviously most of the HIV and viral hepatitis programs are discretionary funding other than the Medicaid side. So that's really at play right now.
Let me just add, just to say, I think over the last several years, I think one hopeful development has been just the increasing recognition among policymakers, members of Congress, HHS staff, White House staff, of the growing burden of hepatitis. And so I think at least the information and the education is paying off in terms of an increasing appreciation of what's at stake. So I think that puts us in a better place than we would be otherwise.
I actually want to add one other thing, which is a sort of a positive spin on the challenging budget environment. HIV and viral hepatitis programs are not being singled out in a negative way or being targeted for cuts. The extent that they're in my view, the extent that they might be affected by the budget environment is part of a broader environment. It's not specific to those programs. That may be obvious, but I think it's important to remember.
Great. No, thank you all. Judith?
Judith Feinberg, University of Cincinnati. So we know from long experience that access to good case management has been really crucial to our good care of people with HIV. And now we're moving on to use of patient navigators as well. That should further enhance our ability to keep people in the system. So my question is, because I can't fathom the multiple layers of the Affordable Care Act, is there going to be anything possible within the new structure for patients with hepatitis C who have the same kinds of needs and are often in the same socioeconomic situation as many of our patients with HIV, and similarly for the injection drug users who are, of course, vulnerable to both HIV and hepatitis C? Is there going to be anything there to help us get people tested into care, stay in care, retained in care, that is similar to what we have for HIV through Ryan White?
So I think that taking up on your comment about the case management and navigator pieces and referring back to one of the slides that Jen showed was the need for continued services that are currently supported under Ryan White. And I think that what you bring up is a critical point, that how do we make sure that the promise of coverage, the coverage is necessary but not necessarily sufficient, right? So as we move forward with implementation of the Affordable Care Act and increased coverage, how do we ensure that the case management, the navigator pieces are part of the care strategy as much as the evidence supports them for being part of that. So when we talk about navigators, I mean, there's actually a wide range of definitions of navigators. In some places where the navigator is used, it's around the function is really to help people link to these new coverage possibilities, right? I think in HIV we use the navigator in a more broad term, and then obviously you have the case management piece as well. Your point about making sure that we have the services available for not only for an HIV perspective, but also from a hepatitis perspective is well taken. I think what we need to see are more demonstration projects, more evidence to say, okay, this is actually improving health outcomes. This is actually helping us improve the healthcare system overall. And there's a number of different pieces of work that are being done in looking at that. Specific to HIV, I'm not sure around the hepatitis C if there's anything specific to that, but you should certainly add, John.
No, I think those are good guiding principles. I mean, you're worried about sustainability of wraparound services, or augmenting what you have. We're even further back on that development curve for those types of services for Hep C, mono infection in particular. So I think getting that evaluation data to really show how that is effective and efficient is really, really critical. The other important, care model that we've talked about at this conference is Project ECHO-like telemedicine approaches to augmenting care, which also has their own sustainability issues, but really seem to be of real value and have been evaluated by AHRQ and those data published in the New England Journal of Medicine, and they are being widely adopted. And now how do we get the payer system to catch up with those proven models while we're developing new models? All of that said, we're in a relatively fast-changing therapeutic landscape for hepatitis C, where the newer therapies may be shorter in duration, a better safety profile, more tolerable. And so what you need in terms of navigation and care models may change as that therapeutic landscape changes.
Sure.
I'm sorry, can I just add one more thing, because I wanted to get specific about one of the HIV programs that's actually being funded through the Secretary's Minority AIDS Initiative. So there were just recently some demonstration projects. It's called the CAPAS project that has been funded to 6 different states to actually help link and engage people in care. So one of the goals of that program is to evaluate those programs very carefully and then figure out if they are working, how do we scale those up. And part of this is also looking at some of the care models like telemedicine and other aspects. So this is another example of where we're taking the realigning resources to where we think where the data really shows the greatest needs are in terms of demonstration projects for precisely the things you're talking about.
So I guess I net this out to understand that what we need to do, what there needs to be, is the opportunity for demonstration projects to prove that this would be a good way to manage hepatitis C as well as HIV, and then hope that broader support and funding would follow. So in other words, there's nothing there now.
I don't think it's
I'm trying to struggle with this.
It's not an either-or question. What I would say is that we're able to show some really good outcomes for some specific programs. And then I think, again, going back to the question of how do we adapt and implement across different states and across different communities there's still a lot of work to be done there. So I think it's both looking at the evidence that we have, looking at what's currently covered by the payer systems that are going to be expanding their coverage, and then also making sure that as we move forward that the wraparound services that we have the greatest evidence for actually being effective are supported within the system.
Thank you.
John?
Yeah, thank you. I wanted to ask Jen Cates a question. First, thank you for your presentation, but you mentioned at the end about data collection, and I wanted to ask you about the NA Accord, which is probably the biggest, broadest, densest database for any disease in the history of medicine. So those data are largely there and easily tabbed and paid for. So I guess my question is that going to be used in this, and is there then going to be a way to augment it, and God forbid, changing it in some way?
Thanks. As I really did a very quick review and didn't give any indication of the data sources we did review and find to be strong and included, and NA Accord was one of them. One of the things that we did in the first report that may be of interest is we actually have several tables, including an extensive one that goes into each of those data sets and explains what is available in them and what they can be used for. In the end, for the second report, we were tasked with coming up with the ability to have a nationally representative estimate or tracking people nationally. And we felt that of all the data systems, MMP was probably best situated, also paid for going forward, but that a lot of supplementary data sets still needed to be used. And NA Accord is one of the data sets that we flagged as having a lot of rich information in it, particularly for court indicators and other things. And I think the benefit of going, if you are doing research and want to understand what databases are available or what their limitations are in terms of availability, that report actually lays that all out very nicely.
Just to add to what Jen said, it wasn't an either-or recommendation. It's just that MMP attempts to be much more of a probability sampling across multiple health centers, including ones that are not academic health centers. So NA Accord, by virtue of the patient base, and a subset of NA Accord or parallel study would be CNIX, which was also highly valued. And I think both of those studies allow you to drill deep on certain key measurements, are particularly useful for looking at natural history of HIV, patterns of antiretroviral use, for example, comorbidities. But there's some healthcare utilization issues and some of the behavioral health issues that are not prospectively asked in those data systems. And if we're trying to understand the cascade, part of it is, what are the behaviors of people once they engage in care, and MMP is a little more robust in that regard.
Yeah, and also to add just in general on data sets, the other thing that we did, the committee did, I think is also starting to see movement on, is we looked at other federal data systems like the Medicaid data system and Medicare. As everyone here knows, so many people with HIV are on Medicaid. And to a lesser extent Medicare, but neither of those are HIV-specific data sets, but there's a lot of data within them. And we tried to highlight that and the ways in which the federal government can use those data sources to get a lot more information on people with HIV than it currently is.
Put John Ward on the spot about where we're headed for with HCV. In a variety of forums, you've shown data on the fact that the impact of HCV is going to peak and then decline. I wonder if you could expand on where you see HCV in 20 or 30 years in terms of prevalence. What factors do you think are going to be the most important in its decline? And are the directly acting agents really at a point where we can be confident that they're going to hasten the decline? And again, I would hate it if somebody asked me that question, but I'm asking the question.
But you did it anyway, so that was great. Well, I don't have numbers for you to really give you a decline. They certainly, as we have, modeled in one way, if you accept the fact that upwards of over 1 out of every 3 people living with hepatitis C over the course of their lifetime will succumb to an HCV-related disease, then with an intervention of this birth cohort strategy, we can save 120,000 lives among the 3.2 million persons living with hepatitis C. So that gives you some idea, and that model was based on various observational data of disease progression, but also based on the relatively inadequate treatment coverage that currently is the state of affairs now in the United States, with only about 12% of people actually receiving treatment. So the benefits of doing more are that we're going to have better treatments that are over 90% effective, shorter acting, safer, tolerable. Then cost will continue to be an issue that will can limit access. We were able to successfully overcome that barrier for HIV. The question for the nation is, are we going to be able to overcome that barrier for hepatitis C? even though I tend to speak slow because I'm from the southern United States, I have a real sense of urgency about what we're facing right now. We have, one out of every 4 people already have cirrhosis among this population. That means they're already have indications for treatment, and unfortunately, treatment is less effective if you already are at that stage of liver disease than if you can catch them early. So we really have to do something in the next 3 to 5 years if we're going to have the impact that Henry is referring to prevent morbidity and mortality among those persons who are middle-aged and older Americans who are living with hepatitis C. So that's our challenge, is to improve care, improve screening, linkage to care, so that these treatments that are really coming, very much like, the cavalry coming to save the day, they're really coming for us. There's a question for us as a nation: are we going to muster all the political will, the healthcare resources, the public health resources that we so effectively did over the last several decades for HIV? Are we going to be able to do that for HCV, so that in 20 to 30 years we can say we made a difference in the lives of these 3.2 million people currently living with hepatitis C? Meanwhile, we have continued transmission that has been evidenced in this conference among a new generation, a second generation of persons who are becoming infected with hepatitis C, primarily through injection drug use. Unfortunately, we still have large outbreaks in healthcare settings that pose an additional threat. We have HCV transmission among HIV-positive gay men. So when you have a disease that is this prevalent and pervasive, transmission continues to occur. So as we lower prevalence, we can lower force of infection and really make a difference in preventing transmission, and begin to talk about treatment as prevention for HCV as we do for HIV. Fortunately for HCV, we have curative therapies, and even more so in the next 2 to 3 years. So we really have an opportunity, if we do our job right, of really beginning to talk about the elimination of HCV, as an achievable goal for the nation over the next 20 to 30 years.
Great. Thanks, John. So we have 2 last questioners, and we're running towards the end of our time. So Daniel and Cal, I'll ask you each to ask your questions succinctly, and then our panel can respond.
Thanks. I'm a simple guy. This is a question. Hearing about the National HIV/AIDS Strategy and the Viral Hepatitis Action Plan back to back made me remember that neither of them go into substantial detail about HIV hepatitis C co-infection. And I'm wondering about where there's opportunities for synergy. John, you mentioned a forthcoming challenge about refreshing or advancing the Viral Hepatitis Action Plan for 2014 to 2016. And Grant, I'm wondering if you have some thoughts where we're looking at 25 to 30% of people with HIV being co-infected, especially as we're starting a conversation about Ryan White Care Act reauthorization. I think there's an argument that at least under the current treatment paradigm, Ryan White has not necessarily served co-infected people as well in terms of managing their liver disease, given that hepatitis C-related liver disease remains a leading cause of death for people with HIV. So that's the simple question.
Great, thanks. And Carol, your question?
The question to the panel is, given the fact in chronic hepatitis we don't have time, and how urgent this is, and also how inadequate our data is, whether it's 3 million with chronic hep C, others including Brian Edlin and all have calculated it's 5 million potentially with chronic hep C, whether it's 1 million with chronic B or 2 million with chronic B. We're not counting the foreign-born, we're not counting the incarcerated, those who are institutionalized, those who are non-English speaking. So whether we've got 5 million with B and C together, or we've got 7 million with B and C together, the number who are standing at the edge of the cliff, and I would love if in B and C we were looking at the kind of cascade we have with HIV, because then we go, okay, a little more push and coordination. So from the federal level and with the community and with professionals who are here, how are we going to change the dial and do it almost overnight for chronic hepatitis? Because we can't wait for another this summit in 2012, if we're here in 2018 and saying, well, we were able to move those who didn't know their status from 75% to, 69 or 68%, that's not going to be enough. And it's not as if it's just going to be mortality, but if you look at Medicaid and Medicare databases already, we're spending a huge amount of money, but we're not spending it wisely. We're spending it for failure at the end of disease. So those expenses are happening on the healthcare system, and I know you want me to stop. I'm not hearing, I haven't heard yet how we, increase the flame on the pressure.
No, important questions. So co-infection and the sense of urgency that Carol's conveyed.
Well, I think that the question around the synergy piece is really important. I think it actually has been built into some of the system. As an example, under Dr. Koh's office, with the leadership of Dr. Valdesari, the Hepatitis Action Plan is their goal, their role to implement that. Their role is also to implement the National HIV/AIDS strategy. So I think that there are a lot of natural synergies within the federal government around moving that piece forward. There are a lot of things with increasing flexibility of funding, for instance, within the CDC, about how funds can be used to address HIV and other infections such as hepatitis as well. So I think that there's some naturally, there's some obvious synergies there that are built in as we move forward to improve health outcomes. The Ryan White piece is a really important part of the conversation. I would ask that we think of as the whole healthcare system is expanding and coverage expands. Certainly, how and where and Ryan White services fit into that complex puzzle, I think, is still something we're all trying to collectively figure out. But I would also say that in this shift, we're covering millions of Americans, including, I would say, I think one of the questions is what's the number living with hepatitis C that are going to have increased coverage. I don't know if there's a number on that, but it's certainly almost surely in the tens of thousands, right? So if we think about what this is doing and how our healthcare delivery system is changing to increase coverage, I think it goes back to the questions of, the second question about how are we using our resources most effectively, how are we making sure that the care piece is not only improving health outcomes, but also saving resources in the long run. So I think improving health outcomes, improving community health, and improving the delivery of the healthcare system, which are critical pieces of the Affordable Care Act. We need, as a community that has focused on HIV and hepatitis, certainly to keep the excellence around that, but also to embrace these broader concepts and show the evidence with regard to what we do, the research that we're doing, to make sure that the promise of this system is actually transformed. So you're not taking care of just the HIV when somebody who's co-infected, you're taking care of the hepatitis, so that's being done in a way that is improving health outcomes, and that's being done in this broader healthcare system. We've cobbled together, I think in HIV we have remarkable progress in terms of the medical home models, in terms of realizing what wraparound services are needed, but we've also sort of developed a siloed system, and that's really a historical basis. There have been very good reasons for that. I think now the question is, how do we embrace the transformation of the healthcare system, maintain the excellence, and how do we figure out, how do we let go of some of the exceptionalism, but still keep moving forward with the expertise and data that we need to really realize the promise of the national strategy and the Hepatitis Action Plan.
Thanks, Grant. John?
Excellent thoughts. I think, to Carol's point about how do we turn up the heat, I think we are slowly turning up the heat. I think it's how can we increase incremental change, but I think the addition of viral hepatitis to this conference is a one positive development. I appreciate Henry's efforts at the infectious diseases and Dave Thomas's efforts and Carol's at the IDSA to bring IDSA more into recognizing this as a priority for their organization and for their members. And we're going to be, we are progressively meeting with other professional organizations to increase their interest and engagement. It's really, I really would call on all of you in the audience to really begin to consider viral hepatitis as a peer level importance for you as you go about your work with HIV, if you're not already working on hepatitis. and hopefully you recognize this need, because we really need the help for both infections. And so we look forward to developing the collaborations that are evidenced in this room. Thank you.
Grant, final word.
I just wanted to, again, thank everybody in this room for all the research you've done in terms of helping move things forward in terms of improving our health outcomes and our healthcare delivery system. Just to ask you all to think about the most salient research questions as this transformation moves forward. What are key questions? And we have, 4 more years, at least, 4 more years of administration that is very evidence-based. And to be able to bring forward peer-reviewed data to say, this is what we know, this is the science, that has really profoundly influences decisions and policy making. So just to thank you all and ask for, going back to the collective response, the federal government is certainly a key partner, but we really need to keep the science to help us move forward and to get to the answers to some of the questions that were raised today. So thank you.
Thank you, Grant. I want to thank our panel for a very informed discussion. We ran a little over, so very quick 5-minute bio break and get your coffee. Please come on back, because our next panel is also quite fabulous. Thank you.